Hello, my name is Dr. Fatma Tariq, and today I will be talking about polycystic ovary syndrome. So, what is polycystic ovarian syndrome? It is a very common condition affecting women of reproductive age group, that means any time from 11 years to 49 years. According to its definition, it is defined as a heterogeneous clinical syndrome categorized by hyperandrogenism, menstrual irregularity, and polycystic ovary morphology, in which other causes of androgen excess have been excluded. As I have mentioned, it is a very common condition among young women who are in their reproductive years. Therefore, it is worth mentioning here that how common it is. According to the World Health Organization, polycystic ovary syndrome affects an estimated 6 to 13% of women of reproductive age, making it one of the most common endocrine disorders in this demographic, with a significant proportion of cases remaining undiagnosed, up to 70%. Some studies conducted suggest some potential differences in its prevalence across ethnicities, with higher rates observed in certain populations like Middle Eastern and Black women. In addition to this, another data published by the World Health Organization suggests 116 million women are affected by PCOS globally, with about 1 in every 10 women in the UK. So, what causes polycystic ovarian disease? Among the causes, the fundamental pathophysiological defect is unknown, but both genetic and environmental factors are thought to play a major role. It is believed that PCOS runs in families, especially in women who have first degree relatives, that is, siblings and parents with this condition. Several other factors such as obesity also plays a role in PCOS associated with insulin resistance. Moreover, higher levels of male hormones called androgens prevent ovaries from releasing eggs, that in turn leads to irregular menstrual cycles. In addition to this, there's also some low-grade inflammation that leads polycystic ovaries to produce androgens that can lead to heart and blood vessel problems. Let us now discuss the clinical features or the symptoms or signs we should be looking for in a patient presenting with PCOS. The most common presenting symptom is oligomenorrhea or amenorrhea. That means either complete absence of periods or there is less flow of periods. This is possibly due to anovulation. About 70% of patients present with menstrual irregularities as their first symptom. The second most common symptom observed is hirsutism. About 25% of patients also experience acne or male pattern baldness. It is noteworthy here that hirsutism or increased facial hair growth is in PCOS is slower in onset as compared to that in ovarian or adrenal tumors, where it is rapidly progressive and more likely to be associated with virilization. Apart from this, patients with PCOS also have obesity, infertility, mood disturbances, or depression along with obstructive sleep apnea. There are some associated risks with PCOS that include type 2 diabetes mellitus, dyslipidemia, endometrial hyperplasia, and carcinoma. PCOS is frequently associated with the risk of developing type 2 diabetes or dyslipidemia. Therefore, they should have an annual screening of fasting glucose and fasting lipid profile. Additionally, in case if such patients fall pregnant, then they should be screened for gestational diabetes mellitus. The complication of endometrial hyperplasia and carcinoma should also be followed up. So, in order to confirm a clinical diagnosis, we need to run some investigations. The blood tests include serum testosterone and LH concentration to check the level of elevated male hormones in the body, and LH to FSH ratio that is usually elevated in PCOS. We also need to find out about the sex hormone binding globulin, which whose levels are usually low in PCOS. Then another very important investigation is pelvic ultrasound, in which we have to look for the presence of numerous small multiple follicles. So let us now discuss the treatment of PCOS. The management of PCOS mainly depends on the patient's symptoms, as not all patients present with the same symptoms, like some may only present with menstrual irregularities or some may have hirsutism and obesity only. Therefore, the treatment is always patient centered. I will now discuss the management of each complaint separately. Weight loss is the key and fundamental treatment strategy for controlling the symptoms of PCOS. So, in order to lose weight, the primary strategy for is lifestyle modification. It is believed that weight reduction in obese female with PCOS improves insulin sensitivity and significantly reduces hyperandrogenism. Just by losing 5% of their weight, obese females with PCOS show improvement in hirsutism, restoration of menstrual regularity, and fertility. We can also add metformin for weight loss, as it also improves insulin sensitivity with a corresponding reduction in serum androgens and LH concentration and increases the sex hormone binding globulin levels. Before starting it, patients should be warned of its gastrointestinal side effects, and in the event of patient experiencing them, a modified release preparation of this medication can be used. For hirsutism, the main aim of treatment is to slow the growth of the new hair. Medical treatment is usually combined with mechanical methods such as laser therapy and electrolysis. Before starting this treatment, patients are counseled about the slow improvement of the process and recurrence of symptoms as a possibility or discontinuation of symptoms. Additionally, they are also counseled about the use of adequate contraception, as the medical treatment can lead to birth defects. Anti-androgen treatment is given to slow the effects of hyperandrogenism. Infertility can be treated with weight loss and ovulation induction therapies. Lastly, acne is also treated by medical therapy such as oral antibiotics, retinoids, and isotretinoin. Thank you for listening. Hopefully, this presentation was helpful for you.